The picture is right. Everything else regarding me in your booklet is wrong. But now the mic is working. See, thank you, Malos. And we'll pass to my case, which is from Romania, where I am. And it's quite a challenge for us. And stick with me till the end, and you'll find out why. And we appreciate your input at any time point. So we'll spin around our case, not the nice tile that you showed us in the city. So we are all here and working with the HIV for her. So these are my disclosures. We'll be talking about a young female that now is 29 years old. She was born HIV negative and she was infected during her early childhood by the epidemiological accident in Romania, as are a lot of young children at that time point. She has a family of 7 siblings and she was the only one positive at that time. So just to have the flavor of it, in Europe we are in the top spot regarding young adults and young females as well, Romanian type, and also this is a distribution for the population in Romania, half and half, half men, half female, with that nice young age around 30 years old nowadays. So they were all infected in this time of their life, and now they are reaching the time point that I mentioned. So she was diagnosed when she was 3, as she had episodic seizures and was treated, receiving treatment with levetiracetam at that time point, and only 5 years later she was put on therapy in 2003. At that time point, her CD4 count was 17. It is not me, it's you. So just to look, we have seen drug-drug interaction at the time point with the treatment that she received and with the first treatment, history of her treatment. So starting 2003, she was treated with everything we had available. All the drugs, all the combination that a child could take at that time point. This is just some of her co-medication that were available into the data file at the time point. There are many. I don't want you to read through all of them. I just mentioned the color scheme that we have talked about it, and they were all mentioning before. So just to have the journey in her childhood, so to say, these are the treatments that she was receiving, and as you can see, she was not doing that good. So starting her early teenager's time, she was detectable, and she was detectable on the viral load for HIV as well, as you can see over here, regardless of the treatment that we have changed. Of course, PI inhibitors were there all the time, and we changed the backbone. So in 2015, we had a problem with a young lady. This is her medication at the time point. We have seen her in the clinic, plenty of them, for different things that she was undergoing. And we did resistance test. With all that viral load that you have seen, you can imagine the resistance test for her. I will not go into the detail, but I can tell you that she had resistant on everything, on PIs, on NRTIs and NRTIs and integrase inhibitor, and also on tropism. So maraviroc would not be an option for her. So in 2006, how is she? Her CD4 count is 8 cells per ml. Her viral load is really high, and I forgot to mention, but she was co-infected with hepatitis B till the beginning. So we are dealing with HIV, hepatitis B in a young female. So her diagnostic at that time point will be HIV infections, of course, C3, chronic hepatitis. She was really thin with wasting syndrome. She still had the seizures that she was on treatment, and at that time point we identified some hepatic lesions. Of course, she was put on everything on prophylaxis. I will not go into detail, with higher dose for PCP, for MAC, and for toxoplasmosis. So she was having fever and seizures. We had to rule out TB, as Romania is also one of the countries where TB is really important, and also other complications like neoformans, and we also needed to exclude lymphoma at that time point. And the lesions, hepatic lesions that I have mentioned, we did a CT scan, and we wanted to see if they are specific for anything. They were non-specific, and we also did TB PCR for them, and also multiplex to rule out any other infections with bacteria, fungus, and the others, as she was febrile at this standpoint. And this was the treatment that she was receiving. She was receiving tenofovir, 1,200, boosted with ritonavir. She was receiving tenofovir. She was receiving FTC and raltegravir at that time point. So we have to think about the drug-drug interactions, because she was replicating on HIV, she was replicating on hepatitis B, as you can see over here. I do not want you to read this chart. It's hard for us to read it, and we wrote it. So this is just to emphasize that we have the prior resistant test for her. This is the latest resistant test that she had. And we wanted just to see what options can we have for these patients regarding antiretroviral treatment. As you have talked before, usually when you need to look at the drug-drug interaction, you may change something in the heart treatment. With our patient, no, because by the end of adding all that up, all we have available from the antiretroviral class were only two classes. So what we did, we put her on double dose dolutegravir. We still have her on dolutegravir. We added etravirine and tenofovir and fostemsavir. So she was involved into a compassionate clinical trial with access to the attachment inhibitor, because it was her only chance at the time point. So we tried to push forward with her and see how it goes. In 2 years, she was doing pretty well. Her CD4 count kind of recovered slowly at the beginning, but remember, first she started with 1 CD4 count, then we got back to 8, and in 1 year we got to 24. But 2 years later, we have around 250 cells, and the viral load was below 50 for HIV and below 20 for hepatitis B. So we are quite happy. She was happy, everybody was happy. But I could not finish the story right now. She came to our checkups, regular checkups, pregnant in 8 weeks. And also, when we did the full checkup, she came up with antibodies for hepatitis C. This is something new. We didn't have that into her blood till that time point. So what we are dealing now is HIV, hepatitis B, and hepatitis C, and a pregnancy. We looked at the clusters that we have in Romania regarding the patients. So her genotype was F1 from the pediatric cohorts over here, and she was along this side. So we wanted to see around her hepatitis C. It was not an acute hepatitis. We didn't have the transaminases high, but antibody was positive, so was the viral load. So we are dealing with a challenge for us and for her. And we are talking about treating hepatitis C. What are the available DAAs at that time point? How can we stick that to the treatment that she has? And what about epidemiology factors and putting all that into context? So we still have a long road ahead, and we wanted to see how it would go. Looking at the data that we have for our patients, when we see co-infections, like when we see superinfections, so hepatitis C on HIV, we usually see them independently. So with B and HIV, they go along. So half of our patients in Romania also have infections in the past with hepatitis B. But when we talk about C, its transmission occurs during some time point, usually in IV drug users. So we try to talk to her and see if anything went wrong during that period, and to try to identify any source of that. Her genotype for hepatitis C was genotype 1b, the most prevalent in Romania, around 90%, but is not the one prevalent, as you can see, really in the IV drug users. We go with 1a, and now more recent data, we go with 3 and 4. So we have HIV, resistant HIV, for which we don't really have that many options. We have hepatitis B, and we have hepatitis C, and we have the regimen for HIV that you can see over here. we have to think about PK data in pregnancy, and we have to look at the antiretroviral treatment, and also we have to think about the baby because she really wants this baby, and to see if we can do anything regarding PrEP, and of course, should we or should we not treat hepatitis. So we tried to tick all the boxes, so to say, and we went with the first one. We look at the guidelines regarding what's recommended during pregnancy in HIV. So the guidelines will say if she's on the current treatment, stick with it. With her, we have no other options. So whatever we'll try to change, it will not work. Of course, there are some recommendation and also regarding dolutegravir that we will not talk about it, but of course she was on that treatment double dose at the beginning of the pregnancy. So again, looking at the chart, I find this chart helpful because she is one of the patients that will be on treatment. She became pregnant, and regarding NNRTIs, the recommendation should be just continue with them. What about NNRTIs? What will be the recommendation regarding the treatment that she has? Etravirine and also has over here, so we will continue with that as well. Regarding PIs, the only options for her due to the resistance is darunavir. So she will be on darunavir, boosted with ritonavir, and we will continue her treatment. Regarding integrase inhibitors, she is receiving dolutegravir double dose because she has resistance to dolutegravir, that I will not go into the details, but she's really a tricky one, so we continue the treatment as well. Remember, after years and years of therapy, she is undetectable, and that is really important as she's also pregnant. Unfortunately, as I have shown the big chart, we could not give her Maraviroc because she is X4, so that will not be an option, neither Fuzeon for her, unfortunately. So combination, you have all the recommendation regarding what you should do in pregnancy, but with her, again, the options are really limited to the only scheme that she has at this time point. Of course, the attachment inhibitor you'll not find into this chart at this time point, but the PK data are available regarding that. So looking at PK data in the literature, of course, there are recommendations what you should give, what you should not give, but we wanted to see what we can give to our patients. So we did TDM levels, and we wanted to see the levels that the drugs will reach for her, for our own patient, and we monitor her pregnancy really close during all that period. So the question will be, should we treat or should we not treat hepatitis C? What will you do? No. You can wait for her to deliver the baby and you will continue. We did a fibro test because we cannot do a fibroscan. She's pregnant and her fibrosis is F3. Will you treat her? No, you will wait. You will wait because the transmission rate, the maternal transmission rate for hepatitis C is quite low. So she will deliver and we will see. Well, we assume, looking at every guidelines, what should we do with her and with genotype 1b that she has, with all the context for this patient, what will be the available treatment for her. At that time point, we only had available treatment with sofosbuvir ledipasvir for patients in a compassionate study. So we wanted to see how that works, and we also could do TDM for her and see how that works. So we took a chance, so to say. We gave her the treatment for hepatitis because if you look at the statistic, when you have more drugs, more infections with co-infections, HIV, hepatitis B, or hepatitis C, the risk of transmission to the baby is higher. And with her context, we really wanted to do everything for her. So we treated her and we tried to manage all the drug-drug interaction with all the drugs in her pregnancy. This is a chart that Fiona mentioned. I will not go into the details. We just measured and we adjusted the doses for her. So the treatment Was done by a team, of course. Our infectious diseases, we also work with a gynecologist, we also work with a pediatrician neonatal service in order to have the delivery as good as possible for her, was she's a tricky person. So we have to manage mother to child transmission not only for HIV, not only for hepatitis B, but also for hepatitis C. These are the guidelines that a pregnant woman with HIV will receive in Romania. So she will receive a leaflet with every detail that she needs to know. And these leaflets can be helpful for the doctors if they are not in direct contact with us. They will receive everything they need to know, and also she will receive the prep for the baby, and she will have the syrups and she will go with them. They are in Romanian. Sorry, we don't have the translation for them. Regarding hepatitis B, these are the data for what's going on in European part. So we do recommend that we'll have vaccination, and these are the these are for HIV, and Romania over here is kind of colored. I was wondering and talking with my colleagues, should I show this picture or not? Because I don't think Romania is in the nice position, the reddish one. But remember the cohort of patients that we have, really young women that are at childbearing potential at this time point. So we started with them with that deadly disease, and now we move to a chronic disease for them. So they want to have a baby, they want to have their families, and they are doing so. Unfortunately, we have some mother to child transmission for this kind of patients, so we don't want that to happen to our patient. So prophylaxis with vaccination for hepatitis B. During her pregnancy, she was undetectable during on tenofovir for hepatitis B, but we still want to vaccinate, and these are the data showing that some countries will vaccinate, and you have universal vaccination for HBV at birth, and we have antenatal screening in some countries, not in all of them. So there are some cases of acute hepatitis, and mother-to-child transmission for hepatitis B is quite high, and the chronicization in that time point is higher than in an adult. So we want to do that. I kind of emphasized and told you what we did regarding hepatitis C. We started treating when she was 32 weeks in pregnancy. Will you treat at that time point? So everything regarding the data that we have, and we treated her for 12 weeks. I know it's F3, but it will be a life chance, once in a lifetime treatment that we will give her, and we checked for drug-drug interactions. So what I want to emphasize that we may have all the tools available, but how many of us will use them in the proper way, so to say, in order to get the ladder up and do something like that for a patient? I know that maybe you don't agree with me with the treatment, but I think for her, it was the right decision at that time point, because she delivered 3 months ago a baby boy that we did the viral loads for him. So he's undetectable for HIV, he's undetectable for hepatitis B, and he's undetectable for hepatitis C. She was undetectable during treatment for hepatitis C. The first viremia that we took was 4 weeks on treatment, and that went up to 34 weeks of pregnancy, and she delivered at 39. Her trip, it's quite a trip, so to say, and I welcome your questions, because she's not from Bucharest. This is a city where we treated her and when we tried to manage her. She's from the northern part of Romania, from the countryside, and she took that road on delivery, 6-hour drive, to come to Bucharest in order to get all the team doctors that took care of her for the pregnancy part and deliver that nice baby boy that I was talking about. So these are the references for what I have talked about it, and I am quite in time, and I welcome any question that you might have.